right. That's right. All right. Okay, here we go. Okay, our next section is diabetes and telehealth care. Our presenter is Dr. Tierney Davis Carlisle, Director of Clinical Programs and Strategy, University of Mississippi Medical Center for Telehealth. Dr. Carlisle, Dr. Davis, gotcha, is the Director of Clinical Programs and Strategy. I don't have my contacts in for the University of Mississippi Medical Center Healthcare, a National Center for Excellence in Telehealth, a family and psychiatric mental health nurse practitioner. Dr. Davis has been instrumental in the implementation of clinical programs that address healthcare needs and underserved areas and in areas with limited resources. So let's receive Dr. Davis.
Thank you. I was going to ask you about your class earlier.
She's also
I'm from Mississippi. Okay. Good morning. I didn't tell you? Okay. All right. All right. So yes, I'll kind of redo my introduction so y'all know who I am. But I am Tierney Davis, and I'm from the University of Mississippi Medical Center, Center for Telehealth. I'm a family nurse practitioner. I've been a family nurse practitioner for quite some time. Recently got my psych NP just in December and passed my test this summer. So excited about that. But those are, of course, we've always had access needs in Mississippi, and here with COVID, even more access needs, especially in the mental health arena. But I'm here today to talk about diabetes in particular. I'll start off talking about kind of why is it even important to talk about diabetes. Let me make sure, is there a certain spot I need to be in for those that are, this is good? Okay, for those that are virtual, I forgot that we had some people that are virtual as well. You can go ahead and advance the slide. So I always start my presentations with talking about what is telehealth, because I don't know who's in the room. And I don't want to assume that people know what telehealth is. I have found that even those that have been doing telehealth or using telehealth in their practice, they may think that what they have been doing is all there is to telehealth or telemedicine. So I always like to start off doing this. So it's delivering care, delivering any type of healthcare service, anything with that, using a technological resource. Okay, so telehealth is that all-encompassing term. So digital education, what do they call it? Distance learning, all of that falls under telehealth. So that's the more broad term. Now there are hundreds of real definitions out there. Don't get caught up in the definition, in trying to find the exact definition. You won't find it. Telemedicine is more about a patient interaction or something that is directed toward a patient. So that telemedicine falls under telehealth. So telehealth is that broad umbrella, and telemedicine is one of the things that falls under that. I've listed here the three main modalities for telehealth. We have our telemedicine, which is the distance care via live audiovisual interaction. There are many that only think that is telehealth. And when you're in a conversation, if you're in your organizations and they're talking about, we need to start doing telehealth, you need to ask the question, what are we talking about here? Because they may only be talking about live audio visual, but there's so many other things out there that you can do. So you want to make sure that that is clearly defined in the conversations. And we use this in our organization for so many things, but examples would be, emergency medicine, specialty care. We have a direct to consumer, program for our corporate health. Then there's store and forward. Store and forward has been around a long time, even before they were using the term telehealth or telemedicine. I'm from as Dietrich said, we're both from very small towns in Mississippi where you have nothing, and there's still not much in our small hometowns. But I can remember going to the hospital there, and they would take an x-ray. You know, you have a fall and you got a big swollen limb, and they take the x-ray, and then you're waiting to hear if your arm is broken, and they tell you, well, we got to wait on the radiologist, you know, to read it. Because they don't have a radiologist in the hospital. Well, that was storing forward even then, you know, because it was in the system. The radiologist was looking at it from wherever they were, and then they were making a determination, you know, about whether it was broken or not. So that's what storing forward is. It's stored securely, except what we're doing now is we may be forwarding it from one system to another system securely for them to review it. And then they send back a recommendation securely. So they may never talk to that radiologist. They may not even know who that radiologist is except for the signature. So that's the difference now. But we have expanded that to other service lines like dermatology. And I'll explain that a little bit, because dermatology is actually a part of diabetes care. You know, when you think about wound care and things like that. With dermatology, the way our dermatologists use it is they do have an audiovisual clinic, you know, that is just a part of their regular clinic. You know, they have a schedule with their patients that are coming in person, but they then also have a designation on that schedule that says this person is a telemedicine patient, so they know that they're going to connect with that patient virtually. But also what they have is we have trained clinicians in their primary care clinics. They may be in rural areas or just areas that are far away that don't have access to a dermatologist. We have tablets, and they're not expensive tablets either. It doesn't even take anything really expensive. And they use a software. We give them access to a software where they take the picture, and it's we show them how the picture has to be, for the dermatologist to really get a good view. They store it securely in that platform and then forward it over to the dermatologist. And of course, they have a little kind of intake form that gives like the history of present illness, how long they've had this condition, a little bit about the patient history. How that helps the provider, the dermatologist, is they say that they have a lot of no-shows, and they have a lot of no-shows because of the demand. So you've got a patient that is in a small rural place and, they need to see dermatology. The dermatology referral is done. The visit is supposed to be 2 to 3 months down the line, right? Because of the backlog. Well, in 2 to 3 months, they're either going to get better or they're going to go somewhere else, or it's going to get so bad that they end up getting help somewhere else. So that patient is not going to show up to clinic and they're not going to think about calling and canceling the appointment. So then there's this no-show on that dermatologist schedule. But what they do is they just flip over and do some of their store and forward appointments. So that time is not wasted. So doing this store and forward, what it does for that patient, that store and forward patient, we are able to ensure them that they are going to get reviewed within a 24-hour period. And how it helps that PCP is not only do they get their answer within a 24-hour period, but they begin to learn. So they start learning, oh, if I have more patients that have this condition with this same, history, with this same, clinical presentation, then this is probably what I should do first. This is not necessarily one that really needs to go to dermatology. I can do this first. And then if that doesn't work, then I can send them to dermatology. And dermatology actually likes that. They don't want the topical, the contact dermatitis, the atopic dermatitis. They want the ones that really need to be seen by them. But also what it does for the patient is the patient knows, okay, they have done this and they have said, I really need to go. So if it's going to cause any kind of stress for them to go, they're more apt to show up, to say, I really do need to go because dermatology has already looked at it. They've explained, I need this patient to come because I need to do a biopsy, but not one of those visits where it's taken $100 for them to get somebody to bring them, to the visit. It's taken a half a day because they had to drive 2 hours to get to the dermatologist. They've sat in the office, 2 hours to wait, and then they've been seen. And then the dermatologist says, you're going to have to come back, in 2 weeks to have a biopsy. So that's where that has helped in that sense. It's similar, for ophthalmology, and I already talked about radiology. And then there's remote patient monitoring, which we will talk about more in depth because it has really been helpful with the treatment and management of diabetes. But this is where we are giving patients devices that they can have in their homes and a care team that is connecting with these patients remotely to help them learn how to manage their diabetes. But they're also serving as liaisons between the patients and their care provider. So we'll talk about that. Next slide. And I already mentioned some of the benefits of telehealth, but definitely patient satisfaction is they're getting timely access to care that they would not normally receive in their community. So think about the patient who knows that the dermatologist is 2 hours away, who has just received, a decision or at least some information, some answers about this rash or this wound that they have had for quite some time, but they received the answer in 24 hours. They're happy now. I'll give you a good example of our emergency department story. Where the town I grew up in, there is no emergency department, but there's one 10 miles away. They used to call that the Band-Aid station, of course, when I was growing up. Like, if you go over there, they're just going to put a Band-Aid on you and tell you to go to Jackson anyway. And Jackson was an hour away. Well, because of teleemergency now, people have learned that if you go over there, they can handle most things, but what they can't handle, they can connect with Jackson using teleemergency, and you will be stabilized by that, provider that through teleemergency, and you may be able to go home, or you may be able to stay, even if you have to be admitted to the hospital, you may be able to stay in the hospital in Lexington, which is that hospital, or if you need to go to Jackson, they're going to already know about you. When you come to Jackson, the same provider who has stabilized you already knows you. So when you get to Jackson, they don't have to repeat all those tests, because prior to that, that's what they did, because they didn't trust what happened in the small rural hospital. But since they were a part of it, they now know, and they know what to expect. Some of our partners have experienced increased revenue. Again, those hospitals that are doing teleemergency, they are experiencing increased revenue because they're not having to send all of their patients out. So they are getting stabilized there. And if the patient needs to be admitted and they have the services, the resources to provide the care needed, they admit them there. Versus before, it was like, oops, this one needs to go to Jackson, and they send them to Jackson. So then you've got the revenue going, to another facility. Provider satisfaction, reducing burnout. I mean, there is nothing like continuously having patients present and you don't have what you need to be able to take care of them over and over and over and over again. So it helps with that. And then specifically, I'm going to highlight the things that are related to diabetes until we get to that, but improve clinical outcomes. So I said I was going to talk to you about remote patient monitoring a little more in depth. That's the focus of remote patient monitoring, is improving the clinical outcomes, reducing the hospitalizations and ER visits, but also most importantly, empowering the patients, teaching them how to manage their chronic disease. Because we know that no matter what we do in the clinical setting, it's up to them. When they get home, they need the tools, they need the resources, they need the support. And that's what we provide with remote patient monitoring. To the next one. Just want to give you an idea of where I live, if you don't already know, and why we have to do so much work with diabetes. And I did update these numbers to the most recent numbers, but this is America. I start with America as a whole first. 37 million Americans are living with diabetes and 96 million living with pre-diabetes. So if we don't do something, those 96 million are going to go on over to diabetes, and we certainly don't need that. And that was 2016, and that was the latest data that I could find. And of course, we know that diabetes has a significant impact on quality of life, and then lack of access to care has a significant impact on who has prediabetes. It's not always that the people are doing something wrong. There are so many factors to why people experience the things that they are experiencing. We can go on to the next slide. And this is just an infographic that really drives that home. So our population in Mississippi is about 3 million. And then you see in 2014, about 15.4% had diabetes. And then in 2021, we're at 14.4%. Now, we don't know if that's real or not, but that's what we don't know if that's real improvement. I would want to know why, but 75,000 don't even know they don't even know they have it. And then 814,000 people have pre-diabetes. That's a lot of people. That's a lot of people that have pre-diabetes. Economic burden. So the cost of diabetes. That's very important. Everything goes back to the dollar. Right? So if we're spending a lot of money caring for people with diabetes, then we don't have that money to do other things that we may need to do with it. And I would love to see it flip and see us spend more money on prevention than we do actually caring, for people with diabetes, but we're certainly not there yet. Certainly not there yet. And I just want you to see this, just so you know why it is so important that we focus on diabetes, focus on prevention as much as possible, but also focus on what we can do to empower the patient. We can come up with these wonderful, best laid plans in the clinical setting and give them this list of medications and write all these scripts and all of that. But if they don't do it and truly understand why they need to do it and have the tools that they need, and have the support that they need, it's really useless. We'll move on to the next slide. All right. So during the public health emergency, my job completely changed. Deidre can tell y'all, before March 13, 2020, I was begging people to use telehealth. I was begging people, just try it, just do a little bit, see a couple of patients a week, through telehealth. When you have a patient call the clinic and, you're kind of like, I wish I could just see it, figure out a way to do it. There are so many ways to do it. And most people's EHRs already had the capability. It wasn't like you had to go out and buy a whole lot of equipment, to be able to do it. But of course, everybody was worried about, well, I can't get paid for it. But even so, if it's going to help your patient and it's going to make you more efficient, you should at least try it and see. On March 13, 2020, my whole world changed. I went to bed one day thinking one way. Woke up the next day, I'll never forget, I was in sorority meeting and I got a text message from my boss that said, we need you to come into work because we got to figure this thing out because COVID is running rampant. And we actually had to work with the health department. That's why we got called in to work with the health department to figure out how we were going to screen people that were coming back from spring break. Because we had no way of knowing where people had gone. And of course, we had all of the healthcare providers. So I work at the Level 1 Trauma Center, the only academic medical center in the state. So we had all of these employees coming back and we didn't know where they had been. And there were all of these hot spots that they had identified. And many of them had been to those hot spots. Everybody vacations the same place, And so we had to figure that out, to how were we going to keep them from coming to work, exposing other people. But also remember, we didn't know a lot about COVID at the time, so we were it was overkill, but we didn't know a lot, about it at the time. So that was one side of it. The other side of it was just the medical center in general. how are we going to keep things moving? How are we going to keep patients from being able to get the services they need? But how are we going to protect our providers? Because got all these people coming in and we don't know where they've been, and it was just a lot. It was a whole lot to think about. Many clinics closed. So even with our telemedicine partners, we had patients who were presenting at those sites for services, and those clinics were closed. So while we were still working, though, how are we going to see those patients? So they couldn't get it. Now, I'll say this, those providers who listened to me prior to that and had at least tried it a little bit, or who had been doing it for a while, they were good to go. They were just like, okay, we'll just open up more telehealth slots. We'll train a few more people. We'll call our patients and send them a link, to join the visit. They won't have to leave home and we're good to go. That's what they had to do. But we had many, many more, hundreds more that we had to train to be able to be ready. But we did also see more patients in their homes. You can go ahead to the next slide. All right. So telehealth and diabetes, we'll get into the meat of diabetes. We know that, we already know this, right? That that prevention can be cost effective, but we're still, kind of beating the horse to let people know that we need to do prevention. We need to spend more money, on prevention. Teleretinal screening. So I mentioned the ophthalmology storing forward. This is what we're doing specifically for diabetes, is screening more people using storing forward. So it allows for the remote evaluation of retinal photos. The first time we did this was in our diabetes study we did with North Sunflower County Medical Center. That was a part of the enrollment into the study, is every participant had their images done, had their retinal images taken, and it was stored securely. And then an ophthalmologist who was at the medical center, which is about 2 hours away, 2.5 hours away, reviewed those. He would send the results back. And then if he needed to see somebody, he would let them know, yes, they do need to see, ophthalmology, and he would share, his availability. But if they didn't need to see him, or if they couldn't get to him, then the workflow was such that they would see whoever was closest, if there was somebody close. And then, of course, e-check-ins and audio-visual visits are great for the remote areas. So I stress this all the time. If you're not doing telehealth at all, it may not be something that you offer every patient, but you do need the ability to flip and be able to do that if you need to do it. Some practices don't advertise it, but if they're on the phone with the patient and there's like a real issue, like somebody brought up to me the other day, and I didn't think about this. They said, if you've got a mom who's got 7 kids and it's a single mom, she's got 7 kids, she can't pack up all 7 kids every time somebody's sick. Sometimes it's as simple as that, especially if it's a communicable disease. Yeah, and you don't want them to. So when you don't have the ability to see that person, via telemedicine, or you're not willing, or you're not willing to try to work that out, there present a problem. There's a problem. So look at what you can do. It may be that you don't do all of these things, but that you do some of these things. Next slide. Connected care. So this is getting into the chronic disease management piece of that. And most of you probably know what all of these acronyms are, but I will tell you. TCM, Transitional Care Management. Annual Wellness Visits is the AWV. RPM is Remote Patient Monitoring. And CCM is Chronic Care Management. And what we have decided to call this at the medical center is connected care, because that's what it is. All of it is a means to connect patients to the care that they need. Can you get to the next slide? All right, and this is our connected care team. We have it up there that they're remote patient monitoring because that is what they did previously. They only did remote patient monitoring. What happened was our chief medical officer actually came to us and said, We're trying to start transitional care management, but of course, as with most medical centers, we don't have all the resources that we need, nurses, to be able to do all of this. And you all already have experience, with working with people who are remote, being on the phone, using technology. Is this something that you would be willing to do? We thought about it and we said, well, it actually does fit perfectly, with our workflow. So we put it all together and called it Connected Care. Remote patient monitoring is kind of like what I call like the luxury car of it. Everybody won't need it, but it is what is needed for those patients that are truly high risk, really high risk. Of course, transitional care management is those patients that are admitted to the hospital that need a bridge, between hospitalization and getting to a primary care provider, those that are at risk for bouncing back into the hospital. And then chronic care management, of course, is after all of that, they're doing pretty good, but they still have whatever that chronic illness is, and we're doing check-ins with them. So that team does all of that because that is definitely within their skill set. So for remote patient monitoring, I'm gonna skip to that. Remote patient monitoring, all of the patients that are on remote patient monitoring receive a kit. And in that kit, they get an iPad mini, they get a Bluetooth glucometer, and they get a blood pressure cuff. The kit is already enabled with cellular service, so they don't have to have internet themselves, and they don't have to, pay for separate internet or anything. Yes, people are going to ask me. I already know. They're going to ask me, what about broadband? Because we know that broadband is not great in that area. Mississippi, of course, is not covered 100%, but I have learned that we are better than a lot of states. Our coverage is, and we credit that a lot to having a great homegrown cellular company, within the state that is working daily to have better coverage in the state. So, and then also the FCC has been very, worked with us great, in a great way to look at what can they do. They come, every year. We've had the commissioner visit several times and ask, what can we do? And we always tell them, we still have dead spots. We still have issues. We still have, people that cannot afford, to have internet service. And so it's a work in progress. Let me say that. But one of our first steps was to say, if we're going to issue these kits, we don't need to require people to have internet. So it comes in the kit itself. There's full technical support. So there's a number there that they can call anytime it does not work for them. It is also very easy to use. So when the kit comes, there's a sheet in there that says, stop, call your RPM nurse, and it has the nurse's number, and it also has an 800 number. With that also, someone from the company calls them to make sure that the kit works right. And then our nurses know when it was delivered. So we know when it was delivered. A nurse, one of these people, calls them and explains to them how they're going to use it and does the first health session with them. And we call them daily health sessions. They take about 5 minutes. And what it is the exact curriculum from the diabetes self-management education course. So I'm going to tell you why we think this is beneficial. People can't come to those in-person classes at set intervals all the time when they do not have reliable transportation, and have all of these responsibilities all the time. Now, we would love for them to be able to, but they just can't, and they can have the best of intentions, but they can't always do it. So when we're talking to providers about putting patients on this program, that's what we tell them. We say, well, at the very least, you're going to know they got their education, because we do know if they did it. Well, let me say this. We know somebody did it because we know that they opened it, and we know if they went through the session. So we know somebody did it. And after they do the little session, then it says it's time to take your blood sugar, and they do it, and it's Bluetooth. So they do they check their sugar, and it automatically uploads into the system. They don't have to punch their numbers in or anything. So that's less room for error with that. And then who's on the other side is, I don't know what my next slide is. So there's a nurse. These nurses are on the other side at UMMC, and they're working from a dashboard. And on that dashboard, it stratifies the patients based on the parameters that were set by that patient's primary care provider. So it's all individualized. So if all of us were put on the program by our PCP, our targets are all going to be different based on what's going on, with us. And the nurses are only going to get alerts based on our individual targets. So if my goal is for me to be under 300, your goal may be for you to be under 200. And the reason for that is it's just like personal training. So if any of you have seen any of my presentations before, I say this every time. It's just like personal training. If we all went and signed up to a gym and got a personal trainer, all of our goals are not going to be the same, and they don't need to be the same, because if my goal is the same as your goal, I'm going to get discouraged and I'm going to quit, because I'm not going to be able to do what you're able to do. So if my goal is 150, but I've been 400, and every time it's not 150, I'm going to get really discouraged and think it's something I can't do. So they can change those goals every time. Also, the patient is a partner. We're doing what every provider wishes they could do, but that they don't have time to do. But we're doing this on the behalf of the provider. We can go on to the next slide. This is the study that I mentioned that we did in North Sunflower County. I won't tell you every detail of the study, but what I will say is the goal was to reduce their A1C by 1 over a period of 12 months. This is when we first did the RPM study. What we found early on after enrolling about 100 patients on the program is we had already reduced their A1C by 1.7. We did not have any hospitalizations or ER visits for diabetes out of those patients that were on this program. Medicaid was watching, and they asked for the data. We gave them the raw data. They ran the numbers, and they told us that we had already saved almost $400,000 in that group of patients already, just by keeping them out of the hospital. So they helped us to get legislation passed where they would cover RPM for diabetes. So while the study was going on, we were able to get legislation to pay for RPM as well. So we did a follow-up. And at the end of the study, what we saw was that this is one of the things we learned. Remember, I said it was over a 12-month period to start. What we found, though, was that if a patient was going to have a benefit from being on the study, they were going to achieve that benefit within 3 months. So now what we recommend is that patients are on the program for about 4 to 6 months. And the reason why we give that extra grace period, those extra months, is because just like personal training, somebody else may walk in there and be ready to go and catch on really quickly. For somebody else, it may take time for them to really get acclimated, and it may take more work. But if they have 3 good months on the program, they should really achieve a benefit. What we also found is, people get tired, right? So they start off and they may do really well for 3 months, but they're not going to do every session, every time. They're going to back off once they achieve their goals. What we found is they maintained it. Like it was 7.7 at 3 months, and it was 7.8, 7.9. They maintained it pretty well, but they did inch up. So they need something. So now what we're looking at is, what can we give them after RPM? So we put them on RPM, they've gotten the education, we've gotten their A1C down, they're feeling some, results. So for those that qualify, now we're saying they need to definitely go right to chronic care management, because they need somebody to check in with them, to remind them of all those things they learned while they were on the RPM program, to make sure that they have everything that they need to continue with those positive results that they received while they were on RPM. Next slide. This is where we did the study. I just wanted to show you where it is. It's smack dab in the middle of the Mississippi Delta, if you know anything about the Mississippi Delta. It was chosen because, one, that's where our then governor was from, but also it has the highest prevalence for diabetes in the state. And the next slide. And have y'all seen those before? So this is what the RPM program replaces, basically. You cannot make a treatment decision based on that, right? One of the main reasons you can't make a treatment decision based on that is you don't know what was going on. You know, that literally gives you one piece of data. It just tells you that their blood pressure was up or their blood pressure was down. Their blood sugar was up or their blood pressure was down, but it doesn't tell you anything about what was going on. We missed an opportunity to educate right then, because what our nurses can do now is, if a patient's blood sugar comes across and it's 400 and the nurse sees that and it hasn't been 400, they can call the patient and say, hey, I saw that your blood sugar was 400 today or yesterday, you know, whenever. And I saw it's 400. Can you tell me what was going on that day? And the patient may say, yeah, I didn't take my medicine, or it was my grandbaby's birthday and I ate a cupcake and it had a lot of icing on it, and yada, yada. And we do not scold them. That's the other thing. We don't scold them because that's life. But we do talk to them about, if you know you're going to do that, this is what you need to do, because that's life. It's the same. Again, I'm going to go back to personal training. Your trainer tells you on your cheat day, this is what you can do. So we talk about what you can do more so than what they can't do, because we're all humans and that's life, right? Because if we talk about what they can't do more than we talk about what they can do, they give up. They give up. But also, like I said, that's an opportunity to teach. And so that's what we're doing on this program. We're telling them, you know, a lot of, if you talk to patients about why they don't exercise, most of it is because they think we're asking them to do something they can't do. When they're thinking about, when we say, do you go to a gym? You can go to the gym. They're thinking about those people that are running miles on the treadmill and, you know, lifting a lot of weights and things like that. No, what our nurses are talking to them about is who gets your mail out of the mailbox and how far is your mailbox from your front door. Go to the mailbox yourself. Instead of stopping in your car at the mailbox, park in the garage and then walk back to your mailbox. That's what we're talking about. And then once that becomes easy for you, then do something else. And these are the things that our nurses can do, because our nurses are not bogged down in the clinic trying to get to the next patient. The great thing about it is once they are assigned a nurse, that is their nurse. So if they're on the program for 6 months, they're going to be talking to the same nurse for 6 months. So that nurse gets to know them. That nurse gets to know things like, this is a grandmother who's taking care of her 6 grandchildren because her daughter is in prison. You know, they get to know these types of things and work with them on an individual basis. You can keep, next slide, next slide. Next slide. Oh, the other thing about those logs is, y'all know they make that stuff up, right? That's the other thing. I've seen people do it. So like, you know, they make it up. They make it up so they won't get fussed at. You know, and that's the thing, is our patients learn that we're not going to fuss at them, you know, either way. It doesn't match, you know, and I'm sitting there like, you know, I know that you have not been eating what you're telling me you've been eating, and you know, and you've not been taking your medication because it doesn't match up. What we have found though is with this, it matches up, because people have asked us things like, how do you know that that's real? And because it matches, you know, even their engagement. When, remember I told you, we know whether or not they learned or know whether or not they watched those health sessions or did those health sessions, their A1C matches. That's how we know, because we get a baseline A1C and then we get an A1C within 3 months, of course. And then if they continue on the program, we get one at the end. And I'm going to show you some good results too. So this is the vision of the Connected Care program. Remember I mentioned they were just getting on RPM at first, and then once they got off, they were just on their own, going back to their PCP. And now we say they graduate basically, and they go to chronic care management, you know, where we're checking in less, but we're still checking in nonetheless on them. And it strengthens the primary care provider patient relationship. Most of our RPM is, we are serving as kind of a, what do they call it? A proxy. for their primary care team. They refer to us like home health, and we're doing what we do. But what we tell the primary care provider is, patients are not loyal. I don't know why providers think they are, but patients go wherever they need, to whomever can provide what they need at the time. That's who they go to. But if they're on RPM, when that patient has a problem, our nurse is going to say, all right, you've got something going on here that your doctor, your nurse practitioner needs to handle. We're going to call that provider. We're going to send them back to the person that knows them. That's not going to be a time where we're going to say, oh, you need to go to the urgent care clinic, unless it's truly an urgent care need. But we're going to keep that physician or keep that nurse practitioner in the loop. Really going on. So what it does, it strengthens that relationship, because also the patient thinks, my provider really cares about me. They're giving me something more to help me manage my diabetes. So we can go on to the next exhibit. These are the monthly reviews that we do. So this is what we provide to their primary care provider. So they're not left totally out of the loop. So say we got a patient on there, we haven't really needed to call the primary care provider while the patient, over that particular month, but they do get something at the end of the month. We have meetings weekly where we sit down and they take these, the patients who have had something that was outlined. We have a PharmD, we have a physician champion, endocrinologist that sits in the room, and they talk to the cases. And something that we have added since the last time I presented at this conference about RPM is medication management. So we actually do manage the medications. What we have found is a lot of people are on a lot of medications that they may not need to be on. Patients like that when you're able to take something away. What that also does is protecting the patient's organs, because they're not on a lot of, medications that they don't need to be on. But also we're able to help that provider and say, here's what was going on, and this is what we did. And then that provider can just make the update in their EHR. So what we tell them is, if you put the patient on RPM with us and you indicate that you want us to do med management, don't you worry about diabetes. We got diabetes. We've got that, but we're going to keep you in the loop for that. So if they're seeing, but they'll still see the patient at their regular intervals and all of that. So if they're seeing them for hypertension, if they're seeing them for other things, they continue that, but they know that while they're on RPM, we're handling the med management for that. So that they like that. This is an example of clinical outcomes. You see over here, this was from our hypertension study. We dropped nearly 14% millimeters of mercury after 6 months on the programs. That was good. And then here is nearly 20% drop in A1C after 6 months on the program. Next slide. Patient feedback, just to show you that patients do like it. If they use it, they like it. Because again, we're not really, once they figure out we're not really, we are watching over their shoulders, but it's not punitive. Like, we're not fussing at them. It's really to teach them. We've had patients who've had diabetes for 30 years to say they've learned more than they ever have. Now, we know that they've been told this stuff before. We know that this is not the first time that they've been told this, but 15 minutes, 10 minutes in an office visit as the provider is walking out of the door is not going to stick with them. It's over and over again in different ways. And then it's at the time of, it's like I tell my nephew, if you don't know what a word means and you look it up yourself, you'll always remember what that word means. But if I tell you what it means, you're not going to remember that. So it's the same way with these patients. If they got sick, blood sugar was 400, and the nurse called them and talked to them about that, they're going to remember that. Right, same situation. Next slide, please. So this I'm going to share. I'm really excited about this. And does anybody have time for me? Oh, good. Okay. So this I'm really excited about. This is these are some results from a partnership we had with an FQHC. We still have with an FQHC, and we were just kind of testing it out just to see what would happen. And these are patients who were on the RPM program just for diabetes. Y'all see this right here? This patient that was put on the program on June of 2021, A1C was 13.5. And that starting A1C was done in April. So 2 months before they were actually put on the program. The post A1C was 7.6 with being on RPM. And that was done in November. So that's from 7 months difference, because that was from April to November. Yep, 7 months different, but they were only on RPM for 5 months. So that was a 5.9 point reduction in their hemoglobin A1C, but everybody had some of a reduction in A1C. So we thought that was just magnificent. I mean, they did too. And they did too. So of course, this is what providers wanted to see, and they started sending more and more patients. Now, what FQHCs loved about this is their UDS scores. That's what they loved about this. And, we were telling them this is that while we are the ones providing this extra support to the patients and to you, those are your scores, they're your patients, So when you're reporting your ability to manage these patients with diabetes. You're saying in our clinic, we are able to manage diabetes because we have access to all of these different resources. When we have a patient that is difficult to manage, we have something that we can enlist to help us manage this. But again, I'm gonna go back to it. At the very least, even if it's not your patient that you already know is really difficult to manage, if you put them on RPM or something like this, or a program like ours, that they are getting the diabetes self-management education. Now, I'll say this, all RPM is not the same. So if you are employing like an external organization or company to do RPM, make sure, you do your due diligence to see what does all of that include, because all of them don't include the education part. Many of them are adding it though. So it's out there. So if you're looking, also always make sure that you know what it is including. Next slide. So considerations for use of telemedicine. So if you're going to use telemedicine, these are all things, to think about. You have to think about cultural competency, of course. Do you have translation services, if needed? In our institution, of course, we had translation services at the large academic medical center. We did have to piece it together, and say, okay, how are we going to use them in our platforms? We are currently now looking at something else that makes a little smoother transition using that. Ability to use it can be affected by age. Now, don't assume that our elderly can't use it, because with our RPM program, we've had people as old as 80. And one thing about that age group, they are going to do exactly what you tell them to do. So, so we have learned is when we put it in their hands and we say, you do this, and you do this, they can do it. So that, be careful not to think, don't think that they can't do it just because it's using technology or they don't have a cell phone or they never had a computer before. They can actually do it. But you do need to assess that. And of course, willingness is a big part of that. Are they willing? Do they want to know how to do it? But if you show them, they can do it. Provider practice setting. Going into it can be time consuming for the provider. I can tell you at UMC, that was part of the problem. Before COVID, they didn't want to take the time to stop and see how it would fit, into their workflow. So what we told, most of the clinics that they need to do is you need a person. And it does not have to be an expensive person, that goes around, that sets up the rooms before it's time for you to come in, the virtual rooms, that's time for you. So if you need to have one of your med techs to connect with the patient first while you're in another room, doing something else, and then they come and say, yep, we're ready for you. They send you the link, and then that the patient got connected correctly, that the patient is ready for the visit, then that's what you need to do. So we had to help them with things like that. Patients with diabetes may have quality of life concerns. So you have to think about, do you need to have a mental health component, with this? That's one of the things I do love about telemedicine is it does make it a little bit easier to collaborate. because you don't have to have all of your providers in one place. You know, you can see a patient this morning and have them see somebody else that's in a whole nother place, you know, using the system. And then, of course, we already know there are issues with the system. They may not have telephone, internet access, and of course, may not have, you know, money, other resources to do this. Next slide. But it can help. You know, these are all things we have to think about, but telehealth can definitely help. And I'm gonna stop right here. I think everybody has access to the slide. You can go to the next slide. I don't think there's anything much left. No, just that telehealth is here to stay. You know, it can help you. It's up to you to really stop and think about how it fits into your practice, what your goals are, what your barriers are, first of all, and then thinking about how you can meet those goals. And I'll answer questions now.
So your nurses that work have their own panel of patients?
Yes.
Right? About how many is in that panel?
Okay, that's a very good question. We can take about 200 patients per nurse. Now, that's going to vary between systems because what matters is the efficiency of the system. If the nurse is only monitoring patients and not having to do a whole lot of troubleshooting with, you know, technology and other things, that can be difficult. And let me tell you why they can manage so many patients. The system stratifies those patients based on those parameters, those individual parameters. So when they come in on any given day, when they look at their screen, it's going to have a red, a yellow, and a green section. They're going to tackle those red ones first. They're going to look at the yellow ones and see, do they need to do anything with those? Some of them are going to be expected things. Like if they just talked to somebody yesterday because their sugar was much higher than it needed to be, and they're still in the red the next day, they're not going to call them. They're just looking at it because they already know. You know, they know to expect that. So it's very manageable for them because it's stratified for them.
So they are expected to make all a week. Is that what you said? Or?
No, we actually don't even tell them like you have to call them every week. It's very personalized, very individualized. But if the patient is in the red, they have to address it and they have to document it. So if the patient is in the red, they have to say, you know, I spoke with them on yesterday, you know, or this is what we're doing. This is our treatment plan, you know, or they have to reach out to them, you know, initially and establish what they're doing and what they talk to the patient about and, you know, what the next step was. If they're in the yellow, it's really just telling them we need to watch them and see, do we need to get up there? And then even in the yellow, they only have to really do something if it is a repeat. Because again, you may have somebody whose sugar is normally, you know, they've been doing good. They've been in the green, you know, they've been under 100 and it hops up one day and it's still in that yellow the next day, but then it goes right back down to green. The priority is going to be somebody that's in the red. Yes. So for diabetes, they get blood pressure and glucose, but we do have RPM for heart failure where they get scales. We have asthma, COPD. Our bone marrow transplant patients get all of them because they temperature, there's several, it's a long list of things that they can do. Mm. No. No. And I say that because everybody needs something different. We're always looking, you know what I'm saying? Like, you know, can the company that we have now, you know, move to meet the needs that we have? You know, so I would hate to be like, use this company because we may not be with them, you know, the next time around. But you had a question. The same question.
I was gonna ask you, do you know of any companies that interface with the EHR that we use? Because a lot of times that's the thing.
What EHR do you have?
They are on RPMS.
Yeah.
The RPMS testing is different. It's similar to the VA system.
Okay.
So it's like almost like a governmental
You don't
system.
know everybody.
Right. And
Well, most of them don't. So I think most of them don't. But I will say, whenever you're vetting companies, ask them, because that's one of the things that they know is really important. I can tell you when we first started, we were on Epic. And when we first started doing RPM, most of them were not interfaced with Epic and had not done it. And since we've asked that question over and over and over again, you know, we piecemeal some stuff together. And so like now we are integrated with Epic, but it's not like everything, every piece of what we do is integrated with Epic. But now when we talk to more and more companies, they lead with that. They lead with, we integrate with Epic. So if you're going to do more work with them, you'll see that they need to start researching it anyway, you know, how to do it. And even if it's not every piece, it works. So like with ours, our nurses work on that the dashboard I was telling you about. That's outside of Epic. So that's what they see. But then the data that is coming from the patient's biometrics that they're collecting, that does go into Epic.
so I have a question. Then how is that, say for instance, if you were working with an organization like FQC, how do you transmit that data from your system to that?
They don't get all of it.
You know,
That's the thing. They don't get all of the data. They get the end data.
okay.
So like they get that information that's on that continuing care document.
Okay. So
So it's not discrete.
I was about to say,
That's the question.
is it aggregate data? Is that what they get, or is it?
It's not discrete data. So it's just on that document. So now they have to, yeah.
And you could say that these are already internet.
Yes.
Because we have a lot of, more than a lot of citizens that do not have internet in their homes.
Yeah, it's cellular. It uses cellular. It uses cellular for that. Now, and the one place where we found that we learned that if they have a tin roof, they have to step outside. But again, the session it takes them like 5 minutes. So we break it down. Like they may get foot care, for example, they may get something about how to inspect their feet, and it may be in a video this time. Next time, it may just be a quick PowerPoint slide that reminds them, remember when you check your feet to take your socks off and, pull your toes apart, things like that. So it's giving them then, and it may come around like every 6 weeks or so, just so they get it more than one time.
So you, those 5-minute like health sessions, they're not necessarily with the nurse or anything. It's just
No.
videos.
Little videos, and they can do them any time of that day that they want to. So like when they wake up in the morning, if their session is blue, it means they have something to do. And so they know, and it's in like, what's your name?
Crystal.
So it'll say, good morning, Crystal, it's time for your health session. And if it's blue, that means you got something to do, and you do it. And when it does that, it turns orange and it's done. And so the next day it'll turn blue again, and it'll be a different session. And everybody's on the same schedule, but at their own pace. They can do it whenever. If they skip a day and don't do it, then they're still gonna have to do that same one the next day. And so on our nurses side, they can see Crystal did wound care on such and such day. So that's what I mean. Like we know what they have seen and whether or not they've done the session.
And the nurses reach out as needed, but can patients reach out to their nurse?
They can call at any time, but what we didn't activate is because it is not meant to be an emergent service, we did not do it to where they could send us a message, through the tablet and expect an immediate response.
That's when they get their metrics. That 5 minute, right, they start up.
Yeah, and that's approximately 5 minutes, but it's during that health session.
Start out.
Oh, and I didn't say something that was really important. Also, during that time period, it asks them some questions that gives us an idea about what's going on with them. Like it asks them, have you taken all of your prescribed medications within the past 24 hours? And if they say no, it uses branching logic to try to find out why. And that prompts a nurse call too. So if it's like they don't have a script, if that's the thing, then the nurse is going to call and try to see how that nurse can help them get the script. So that would be, of course, a call to their provider's nurse and things like that. It asks them, do they feel any worse today than they did yesterday? Do they feel any worse today than they did yesterday? And then that nurse will know, I need to call this patient and see, what's going on. Do they need care? So we do gather all of that information. And that would be one of the things that will put them in the red, that would say he or she is having a problem. I need to call. I know he has to catch a flight. So.
Please continue to ask questions. Thank you so much, Dr. Tierceny Davis. She gonna get me later on, for coming and presenting to us. Just give her a hand, y'all, and also on the online as well. So just to give you an idea of some of the tribal nations that we have here, would you just briefly tell us what tribal nation you're with and where you're from? Okay, Haley. Okay, Crystal. Mary Keller. All right, and Dr. Willis.
Mississippi Band Choctaw Indians. Philadelphia.
Yeah. Yeah.
I was born in Sunflower County.
Wow. Indianola pecans. You got to know that if you go in that area. And BB King, of course. All right. Thank you again. I appreciate you so much. And we'll be calling you again. Thank y'all. It's been a great session and enjoyed y'all. Thank y'all for coming to Best Practice Conferences. It's been great information. And just thank y'all so much and look forward to working with you all. And we are done.